external and internal carotid arteries branch. The vagus nerve is the only one to go to the thoracic cavity and abdominal cavity. And we mostly are familiar with it as innervating its autonomic components. So smooth muscle and cardiac muscle and glands. But it does do skeletal muscle. So it's put into the skeletal muscle of the lower pharynx and esophagus, and it does all of our laryngeal muscles, all of the skeletal muscles of the larynx. So in this image, and you have this in your lecture notes, the vagus nerve is coming down, exits via the jugular foramen, and is going to, it's a really good color I can choose here, is going to pass down the lateral aspect of the neck and give off several branches. So jugular foramen up here. It passes all the way down through the opening of the clavicle, what's called the thoracic inlet. So it makes its way down into the thoracic cavity, where it's going to innervate the respiratory muscles of the inside the lungs, the smooth muscles of the bronchi and the heart. However, along its way, it does give off several branches that involve the larynx. So up high, right, just behind the angle of the mandible, it gives off a branch known as, and this should be up closer to the ceiling, but it gives off a branch known as the superior laryngeal nerve. Now, to be completely accurate, I suppose you could call it the superior laryngeal nerve branch of the vagus nerve, but I'm happy with just superior laryngeal nerve. And that has two components. So it will divide, and it will send a branch that pierces the ligament between the hyoid bone and the thyroid cartilage. So that's called the thyrohyoid ligament. So it will go into the inner aspect, the lining of the inside of the larynx. The other branch is going to travel down external, here I'm running out of my color combinations, but travels down external to the larynx and functions to innervate one muscle. And that one muscle is the cricothyroid muscle. So rather than write the names up here, I'm just going to put A and B. Okay? A is internal laryngeal nerve, or again, the internal laryngeal branch of the superior laryngeal branch of the vagus nerve. This is only sensory, right? So this nerve provides sensory innervation in the epiglottis. And I really didn't diagram that on our previous models, but that's this leaf-appearing cartilage right here. And it's the only one formed of elastic cartilage, and when you swallow, the larynx moves up, and this comes down to cover the opening into the larynx and keep food from going into the larynx. So the lining of that, the inside of that, is going to be innervated by internal laryngeal nerve, as well as the larynx itself above the true vocal cords. So sensory information to the epiglottis and upper larynx. So essentially, this whole area here, and the lining of the larynx up down to the true vocal cords. that's sensory only. And then the external laryngeal nerve is motor only. And it's motor only to the cricothyroid muscle.
Okay, so wait a minute,
So that leaves us with the sensory innervation of the lower portion of the larynx. So if we go back to this image, internal laryngeal nerve does sensory innervation to all of this area. And we still need sensory innervation to this lower portion, down to the trachea, and a little bit actually farther as well as all the other muscles, lateral and posterior cricoarytenoid, the vocalis muscle, muscles that I didn't name that you don't have to know. So that muscle, those muscles and that sensory innervation is provided by a unique pattern or unique pathway. The rest of the vagus nerve is passing down through this thoracic inlet, going down to the esophagus and down to the heart and the lungs. And a branch of that comes off and curves back up and comes back up behind the trachea to do that innervation. You can see this nerve on this weird looking larynx model. So this white pattern right here is the recurrent, meaning returning to, the recurrent laryngeal nerve. Do you have recurrent infections or recurrent bronchitis or whatever, it keeps coming back? So this is a recurrent laryngeal nerve. On our small larynx models, you can also see it. So here it's yellow rather than white. So here would be the recurrent laryngeal nerve here. And the internal laryngeal nerve right here going through the thyrohyoid ligament. You're not seeing the external laryngeal nerve. That's not shown. So down within the chest cavity itself, we have this recurrence. It's going to be somewhere down here. I'm not going to draw on the wall. It's going to come back up here and provide motor innervation to all the other muscles and sensory innervation to the lower larynx. And that is the recurrent laryngeal nerve. So sensory to lower larynx. Motor to all the other laryngeal muscles. Now it has an interesting side effect, well not really side effect, but correlation with this recurrent pathway. On the right side, when it curves back to come, it curves under the subclavian artery. So it passes anterior to the subclavian artery, sends a loop underneath it, and comes back up into the neck. On the left side, it does that under the arch of the aorta. So it's rather close to the heart, lateral posterior aspect of the aorta, curves under the arch of the aorta, and then comes back up to the neck. Which, sometimes people get aortic aneurysms. We had a former lab tech whose mother had a 10-centimeter aortic aneurysm. A balloon-type aneurysm. 10 centimeters is about 2.5 centimeters per inch, so 3.5 inches. And when that expands like that, sometimes the only symptom is the stretching, is due to the stretching of that recurrent laryngeal nerve, which causes hoarseness. So a change in the voice character up in this area is a result of some pathology in the chest. So physicians have to be aware of that and not focus just on, look in the throat, well, your vocal ligaments look fine, I don't, no problem, go home kind of thing. You have to be aware of looking in other areas, similar to referred pain. Alrighty, so any questions on, again, they're all vagus nerve, alright? but they have different specific functions. This is a picture from Netter. So you're not seeing the vagus nerve itself, but you're seeing number 1 would be the superior laryngeal nerve, 3 would be the internal, and 4 external, and 6 recurrent. So here you're seeing the middle constrictor, inferior constrictor and middle constrictor. So the question says, nerve 3, internal laryngeal nerve, functions to provide, and the answer would be
What sensory?
A.
A.
What nerve or nerves would do B and C?
External laryngeal for B. No? Motor?
Recurrent
Oh,
is
recurrent.
for both B and C.
Oh, that's right.
Because external laryngeal does only cricothyroid, not cricoid. It's just cricothyroid.
So close.
All right, so now we're moving below the larynx, and we're going to follow the airflow when we do pulmonary ventilation on Tuesday, down the trachea, out the bronchi, down the bronchioles, and into the individual alveoli. All right, so today I want to just take us to the bronchioles, and we'll leave the alveolar ducts and alveoli for tomorrow. So here's the position of the trachea with the larynx removed from the top. And if we look at the posterior aspect of our heart model, you can see the relative position of the bifurcation, the branching of the trachea in location with the rest of the great vessels of the heart. So here would be the pulmonary trunk arising from the right atrium here, superior vena cava. Get myself situated here. Pulmonary trunk, aorta, superior vena cava. And if we turn it around in the back, this is esophagus. The white line that you're seeing is what nerve? What innervates the esophagus? Vagus. And in fact, let's see if I can, we're not showing the recurrent laryngeal nerve on here. And then this would be the trachea. So right at this level, about where superior vena cava empties into right atrium, you're seeing the branching of the trachea into right and left bronchi. So that's kind of posterior. So from this view, you can see esophagus is posterior to the trachea. All right, and so line up with the vertebral bodies. May I erase the board? Can I sit with that? So the trachea is the airway. It's still a part of our conducting pathway, and it's transporting air in and to the lungs and out from the lungs. We still need to, it's rather large in diameter, so we still need the cartilage structures to maintain its open availability. When we look at the trachea posteriorly, however, the cartilage does not completely enclose the trachea. We actually have smooth muscle that encloses the trachea posteriorly. Remember what organ I just showed you was posterior to the trachea? The esophagus. So if you've ever eaten a large bite of food without swallowing it, or taken horse pills, or pills for the size of a horse, it's really difficult and you get stuck. And so that would be even more so if the cartilaginous rings were completely enclosing the trachea. So this allows soft tissue, that food being swallowed can bulge into that space. So I'm going to draw a series of cross sections as we move through the various airways and compare the presence or absence of cartilage, the location of smooth muscle, and the type of lining epithelium between those. So in our pattern, the trachea branches, that dichotomous branching we were talking about with embryonic development. You'll notice the right bronchus is more vertical. Not that the other one is horizontal, it's just less vertical. And the right bronchus is also slightly larger in diameter. So if an object is inhaled, the safety pin hopefully closed, or some other object, it most often ends up in the right bronchus. That's where they would check for it first, because of its position. So I'm going to diagram just the plan over here of the trachea. So if you're showing the cartilaginous rings. And there are ligaments connecting each of these cartilaginous rings. And then the left bronchus and the right bronchus. There is a kind of a cartilaginous point, a rise right there at the center of the bifurcation, known as the carina. Kind of helps to deflect the airflow. You'll be able to see that in the sheep lung. Now, before we move into the tissue structures, a couple of points I want to make. This previous slide shows a tracheostomy. A trachectomy is the cutting of the trachea. A tracheostomy is a creation of a hole. Ostomy means a hole, so it has a colostomy, the creating of a hole. It can be permanent or it can be temporary, depending on what's being treated. Sometimes the lungs need to rest. Other times there's problems. My father-in-law had one put in about 5 weeks before he passed away. He was constantly getting aspiration pneumonia. And they'd already put him on a feeding tube, and he wasn't being allowed to eat, but just swallowing saliva and mucus from the lungs was getting from the saliva, mucus from his esophagus and mouth was getting into his lungs. And so they put in a trach. Trach tube is kind of bent at a right angle, and then if it's permanent, it's inflated with a cuff that's filled with air or with sterile saline. And so that would prevent aspiration of other material around the side of it. A temporary trach might be done in an emergency, but it's always done under sterile procedures and in an operating room. No, not that one. Because if we look at the trachea, the endocrine organ that's located right here just below the larynx is the thyroid gland. And as an endocrine organ, that's very vascular. We have 3 arteries and 6 veins in that area. And so if you were to try to do an emergency trach, you would fill the lungs up with blood. Okay, trying to open up all the blood from the thyroid organs and stuff would pour into that. So this needs to be done under procedures where the blood vessels can be cauterized or ligated, tied off, and carefully dissected, exposing the tracheal rings and opening them up. So typically a trach is placed in this region right here, just slightly. They would separate the thyroid gland and then place it just around cartilages 3, 4, and 5. So if you need to do an emergency airway, let's say that you're at Costco, you've got your 2-year-old nephew with you, and unbeknownst to you, he reaches over and grabs a hot dog sample from one of the sampler trays and chokes on it. Okay? And the Heimlich maneuver, nothing's working. Typically, choking occurs with a spasm of the vocal cords, and so the muscles grab tight around that area. So the airway opening needs to occur inferior to that. You do it above it, you haven't cleared any airway. So the best place to do the emergency airway position is a cricothyroidectomy. Right here. We do it up here, again, we're above the vocal cords. Okay? Down here we've got the blood supply and the thyroid gland in the way. So right in here, if you take your finger and run it down, kind of extend your neck, it'll just drop down into a groove. Right there. Oh. And that's the space between the thyroid cartilage and the cricoid cartilage. It has 2 advantages. One, it's above the thyroid gland, so lower blood supply, lower chance of blood filling up the hole that you've created. And 2, if we took a sharp instrument, a pocket knife or a very sharp pen, and we stabbed a hole here to create an airway, if we were in the trachea, guess where we're going to come out? that posterior soft tissue of the tracheal wall. If you do it in the cricothyroid area, guess what you're going to hit? The wide part of the cricoid cartilage. And that's going to stop you from going all the way through. Then you can grab a plastic, hard plastic tube like a Bic, take out the ink cartridge, and place that in there and provide airflow. Okay? Because you're below the level of the vocal cords. If first responders show up, they have the air tubes and they have equipment for doing a cricothyroidectomy. However, they may not be able to do so because, at least the last time I checked, EMTs were not provided the permission or the licensing to do that. You had to be a paramedic. And so if the first responders or the firemen that show up are EMTs.